uveitis in cataract patients, it poses a lot of surgical challenges. It cannot be treated as a run-in-the-mill type of cataract surgery. This type of surgery requires meticulous preoperative planning. The surgery should be technically complex. It carries a lot of risk. So wrong time of surgery and faulty technique can lead to permanent visual loss. Cataracts develop in the uveitic eye secondary to chronic inflammation or as a consequence of long-term treatment with corticosteroids or cholinergic anti-glaucoma medications. There are 4 main indications for cataract surgery in patients with uveitis. The first one is phacogenic uveitis. Here, you should not. There is no waiting period. You have to take up for surgery immediately because the leaking lens protein is the causative factor. So immediately take up for surgery and proceed to control inflammation post-operative period. Visual impairment due to complicated cataract with a pre-operative quiet eye and expected good visual prognosis is another indication for cataract surgery in uveitic patients. Cataract that impairs fundus assessment on treatment in suspected fundus pathology is another cause to take up for surgery. The last one is the cataract that obstructs visualization of the posterior segment in a patient requiring posterior segment surgery. The key point is, except phacogenic uveitis, there should be an inflammation-free period of at least 3 months prior to cataract surgery for all other causes of uveitis. Inflammation is controlled by short-term corticosteroids in chronic cases or may require the use of immunomodulatory therapy for relapsing and remittent uveitis. The aim of surgery is to keep the eyes inflammation-free before, during, and after cataract extraction to avoid complications and ensure best visual outcome. You have to plan the surgery depending on the etiological cause. So accurate etiological diagnosis of uveitis is essential for management and selection of patients for cataract surgery at appropriate time, giving a judicious prognosis. The problem may be anywhere, starting from the cornea or in the angle structures, in the vitreous cavity, a lot of opacities may be there, optic atrophy, whatever may be. The comorbidities can be anywhere due to post-sequelae of ocular inflammation. A detailed relevant history is mandatory. Detailed ophthalmic and systemic evaluation and review of medical systems along with laboratory testing often gives a clue to the etiology of uveitis almost in 83% of patients. As far as visual prognosis is concerned, certain type of autoimmune uveitis, the most common ones like Fuchs' heterochromic iridocyclitis, the results are quite good. Whereas in cases like JIA, juvenile idiopathic arthritis, when it is associated with uveitis, the prognosis is much guarded. But nowadays, a lot of publications are there. If you control the inflammation in preoperative period as well as in the postoperative period, you can guarantee good visual prognosis even for these patients. Beckett's disease, really the prognosis is much guarded because postoperative macular edema due to inflammation is very common in this disease. There will be pre-existing pathologies like optic atrophy and epiretinal membrane are also common in Beckett's disease. In infectious causes, most commonly in our thing, post-hepatic and toxoplasmosis, in such infections, it's better to treat the infection accordingly, then take up for surgery. Again, you can promise good visual prognosis to the patient. Ophthalmic examination gives you 2 clues, that is to assess the visual outcome and to plan surgical strategy. You have to rule out associated conditions like glaucoma, cystoid macular edema, retinal neovascularization, optic atrophy, and macular scarring. All these things should be documented with fundus picture, fundus fluorescent angiography, OCT, and D-scan. Special consent form is required after explaining and making the patient understand before surgery. The surgeon may face various challenges during surgery because of myotic pupil, posterior synechiae, pupillary membrane, calcified anterior capsule, and poor visualization due to band keratopathy. Phaco emulsification is preferred choice in all these cases, but you may need additional surgical steps such as synechialysis, insertion of iris hooks or dilator, the use of trypan fluid for capsular staining, and control of bleeders may be warranted. Intravitreal injection of medications may also be necessary. See, this is the pupillary dilatation. The stretching is happening at diagonally opposite directions to make the pupil little more dilated and have better view for surgery. This is another technique using the iris hooks. Again, here you can expect more of iris trauma. Nowadays, instead of 4 hooks, we prefer 5 iris hooks for better stability and to prevent iris prolapse in these cases. And the staining can also be done with trypan blue in all these type of complicated cataracts. This one is really mandatory to release all the synechiae, not only at the pupillary margin. You have to go under the surface of iris and try to release the synechiae properly before taking up for surgery. The decision making on pars plana vitrectomy should be done by the surgeon, maybe at the time of surgery, or it can be pre-planned. In cases with associated posterior segment pathology and significant vitreous opacities, a combined pars plana vitrectomy may also be needed. After finishing the surgery, even on the table, depending on the type and severity of the inflammation, you have to take a call on intravitreal injections. Triamcinolone acetate can be given to reduce post-operative inflammation and cystoid macular edema. But this carries the risk of increased IOP and posterior capsule opacification. So be cautious in eyes with a history of glaucoma or steroid-responsive ocular hypertension. The other intravitreal anti-VEGF drugs can also be tried in this risky patients for increased IOP. Intravenous methylprednisolone can also be tried on post-uveitic patients. The selection of IOLs should also be appropriate. In a multicentric study, Alio et al. Has compared different IOL materials after Phaco emulsification and lens implantation in 140 uveitic eyes. The different materials were hydrophobic and hydrophilic acrylic, silicone, PMMA, and heparin surface modified PMMA. The silicone lenses, in fact, they performed poorly. The acrylic lenses were the preferred choice. In his study, both the hydrophilic and hydrophobic lenses, they scored equally. But the latest studies recently conducted in 2012 and 13, they feel hydrophilic lenses with sharp edges are far better in such situation, and you can expect less formation of PCO. The placement must be always in the bag. Sulcus IOL, we all know there is chronic iris touch, and this is a triggering factor again. AC IOL, better to avoid. Glued and stitched scleral fixated IOL, more prone to cause cystoid macular edema. You have to think twice before you are planning multifocal IOLs in these patients, because if you have to intervene later with the posterior segment surgery, multifocal IOL won't be the good option. If there are big zonules, better to use CTR before implanting the IOL. Lens placement in children also should be considered meticulously. Whether to go in for lens implantation the first sitting or to take it up as a second stage. Complete washout of the viscoelastics during surgery is essential. Remove any blood clots if it is there. Suture the wound if extensive posterior synechial release was done, if iris hooks were used, and if there is repeated iris prolapse during surgery, better to do suturing of the wound site. Usually they are all younger patients under the age of 30. So in all these patients, you have to do wound suturing. Topical atropine can be used for cycloplegia, but try to withdraw earlier because we want good pupillary mobility. Subconjunctival dexamethasone or intraocular triamcinolone can be decided on these patients. And post-op acetazolamide should be prescribed when there is existing glaucoma, when there is fuchs heterochromia, or the cataracts is so dense and you have used high Phaco energy, and if the surgery was prolonged, on the first day itself, it's better to put them on acetazolamide. The story does not end with cataract extraction and IOL placement in uveitic patients. You can expect early and delayed postoperative complications. The early ones may be fibrinous uveitis. It's unusual if you follow the preoperative protocol. But if there is fibrinous uveitis, repeated subconjunctival steroid is required, half-hourly topical steroid. And if the condition is very severe, use tissue plasminogen activator. High IOP is another complication you can expect in these patients. So it has to be tackled with the relevant topical and systemic IOP lowering drugs. If there is hyperemia, again you have to put them on topical and systemic IOP lowering drugs. If persistent AC wash should be taken up. Cystoid macular edema has to be diagnosed earlier and put them on acetazolamide, oral steroid, orbital depot, or intravitreal triamcinolone. The late postoperative complications may be posterior synechial, IOL entrapment, and anterior capsule phimosis. They may go in for lens cell proliferation, cyclic membrane leading to phthisis, and IOL deposits. Usually for children with juvenile idiopathic arthritis, the traditional thing was no IOL. But the current view is you can use an IOL if the eye is entirely quiet. But here you have to do primary posterior capsular excess and anterior vitrectomy. It's better to avoid combined surgery if possible, that is Phaco and Trabculectomy, due to poorer IOP control and worsening of inflammation. But if you have to do, always use two-site surgery, Trabculectomy first and cataract second. It's better to follow NPJ sliding scale for all these patients with the cataract patients with the uveitic problem. The first type is very quercetin, acute anterior uveitis, where the patient is not on any maintenance treatment. They don't need any pre-op treatment also. In fuchs uveitis, the patient may not be on any maintenance treatment, but it is better to put them on topical Predfor 6 times a day for 1 week and then take up for surgery. In chronic anterior uveitis, the patient may be on low dose of or low strength topical steroids. For them, you have to put them on Predfor 6 times a day for 1 week plus oral steroids. The other one is intermediate or stable chronic posterior uveitis. The patient may be on topical steroids and oral steroids. For them, you need not change the dosage of oral steroids, but whatever NICT or whatever medication they are on, it's better to put them on Predfor 6 times a day for 1 week before taking up for surgery. If it is unstable chronic posterior uveitis, topical plus oral steroid the patient is already taking, but for them, they might require IV methylprednisolone. Post-operatively also, it's better to follow NPJ method. Here the principle is better over-treat and then relax. Don't under-treat and try to catch up later. Review these patients on the 1st, 5th, on 12th post-operative day, then as necessary. If there is high risk, the medications are the following. Again, Predport hourly, cycloplegic 4 times a day, and oral steroid. If the risk is low, then they can be on Predport 2 hourly and cycloplegic only 2 times a day. If you are putting the patient on mydriatic, stop quickly if possible. Oral steroids also reduce exponentially when the eye is quiet. To conclude, I would like to bring out the following requisites. Extensive diagnostic evaluation to determine the cause of uveitis, proper patient selection, zero tolerance to preoperative inflammation, vigilant use of immunomodulatory drugs wherever necessary to control preoperative inflammation, meticulous surgery through thoughtful decision for IOL implantation, control of postoperative inflammation, and early detection and aggressive management of complication. You can come out with good results in these patients.